Okay, picture this. It's 3 p.m. on a Tuesday. You're already, 40 minutes behind, and your hormone receptor positive breast cancer survivor looks you dead in the eye and threatens to literally flush her letrozole down the toilet because she is having 15 hot flushes a day. Sounds familiar, right? We've all been there.
Now look, we know this isn't just about her ruining a favorite silk blouse. Severe vasomotor symptoms directly threaten her adherence to life-saving endocrine therapy. If she stops her meds, her recurrence risk absolutely spikes. Adverse reactions ruin quality of life, which, breeds non-adherence. This is literally a life or death quality of life issue. Elinzanetant and the OASIS-4 trial, Rethinking VMS in Breast Cancer. So, welcome back to the deep dive. Today, we are unpacking a brand new, absolute game changer of a study from the New England Journal of Medicine that might genuinely change your very next clinic shift. We're looking at the OASIS-4 trial and a potential non-hormonal holy grail, Elinzanetant.
Section 1. The breast cancer VMS stoloma. Because let's be brutally honest here, our current toolkit is, well, it's incredibly frustrating. We prescribe these cancer drugs that induce brutal menopause symptoms. We tell our patients they absolutely cannot have estrogen. And then, what do? We reach for off-label Band-Aids, SSRIs, SNRIs, gabapentin. The benefits are modest at best, and we are usually just trading hot flashes for weight gain, brain fog, or totally dead libido. What our patients desperately need is targeted non-hormonal relief.
Section 2. Enter Elinzanetant and the OASIS-4 trial. All right, this is where it gets genuinely exciting, because we're finally seeing a drug that works completely differently. Here is your clinical pearl. Elinzanetant is a targeted neurokinin antagonist. It specifically blocks both NK1 and NK3 receptors. Now, why do we care? Because estrogen withdrawal makes those hypothalamic KNDy neurons, that's K-N-dy, it makes them hypertrophy and go totally rogue. This drug goes straight to the source, calming down those hyperactive neurons and basically fixing the broken thermostat.
So who was actually in this trial? We're talking about over 400 women, right around 51 years old, currently on tamoxifen or an aromatase inhibitor. And get this, at baseline, they were dealing with over 11 moderate to severe hot flashes every single day. That is agonizing. This is our exact patient population, the one sitting in our waiting rooms right now.
Section 3. The data. Sweats and sleep. Now, you and I both know that in menopause trials, the placebo effect is notoriously strong. We need to see a dramatic contrast to actually believe the hype, and, well, here it is. By week 12, patients on Elinzanetant saw a drop of almost 8 vasomotor episodes per day, compared to just 4.2 for the placebo group. The curves separate almost immediately, right by week 1, and they stay beautifully separated.
Let me translate that into a pearl you can actually use in the room today. Over 70% of the treated women saw a 50% or greater reduction in symptom frequency by 12 weeks. Imagine telling your patient she has a 7 in 10 chance of cutting her daily hot flashes in half or better. That is exactly the kind of hope that keeps a patient compliant with her breast cancer therapy.
But wait, it's not just the sweats. The trial showed statistically significant drops in PROMIS sleep disturbance scores, meaning they're finally sleeping through the night again. It also dramatically improved their overall menopause-specific quality of life scores. And again, that relief started kicking in incredibly fast, literally by week 1.
Section 4. But is it actually safe?
All right, time to put on our skeptical attending hats. We've all been burned by wonder drugs before, right? When you block receptors in the brain, what is the collateral damage? Well, the most common side effects here were headache, fatigue, and somnolence. But here's the kicker. Most were mild to moderate. Only a tiny fraction led to drug discontinuation. And honestly, if you counsel them to take it at night, that somnolence might actually help them catch some much-needed sleep.
Now we have to tackle the elephant in the room, which is hepatotoxicity. With neurokinin antagonists, we always worry about the liver, but the data here is super reassuring. An independent liver safety board reviewed everything. There were 5 cases of elevated LFTs, but every single one had other documented causes. 0 cases met Hy's Law. Their conclusion, no substantive hepatotoxicity signal. You can absolutely breathe a sigh of relief on that one. And for the clinicians in the room, here is a high-yield pearl on the endometrium. Because, a lot of these women are on tamoxifen, right? The trial monitored this very closely.
All evaluable endometrial biopsies performed during the trial returned completely benign findings. Endometrial safety was maintained, giving us real confidence for treating our HR-positive breast cancer patients.
Section 5, changing your next clinic shift. Because let's face it, evidence without application is just academic noise. Here's how this actually changes your next clinic shift. Step 1. Proactively validate their VMS agony. Please, don't wait for them to threaten to quit their letrozole. Ask them about it first. Step 2. Note Elinzanetant's targeted potential for a 50% plus symptom reduction. And step 3. Monitor for mild fatigue and headache, but confidently reassure them on the overall safety profile, particularly regarding the liver and endometrial. This trial really is a massive step forward in non-hormonal therapy. But I want to hear from you. How are you currently managing severe VMS in your breast cancer patients? Are you sticking with gabapentin, trying oxybutynin? Drop your clinical strategies in the comments below so we can all learn from each other. Keep staying curious, keep advocating for your patients, and I will see you in the next deep dive.